Hello, I'm Natalie Davis at United States of Care, and today I'm so honored to come together with our partners at Community Catalyst, Families USA, and UnidosUS to talk to the leadership at the Center for Medicare and Medicaid Services. Today, we are in conversation with Administrator Chiquita Brooks-LaSure and Principal Deputy Administrator John Blum about their roles in leading the Center for Medicare and Medicaid Services. This has been a tumultuous time in our world since the administrator and the principal deputy administrator took their leadership 1 year ago. Today, we're here to talk about building a healthcare system that meets all people's needs, about progress that has been made and what is left to do, all with the North Star of building a healthcare system that is accessible, affordable, and fair for all. Thank you so much for both being here today and for your service to our country.
Thank you, Natalie. It really is a pleasure to be with all of you, our partners in this work here at CMS. And I think one of the things that I just felt so strongly when I came in was just what a moment we are living in, just as you said. For so many reasons, I think we have had just a lesson in what it means to our country when we don't have the strongest healthcare system we can. And so I think that it is an exciting time, even though it's a difficult time for us as a leadership team to be here at CMS, because we have just such an incredible role in ensuring an equitable healthcare system. And we're tremendously proud about the opportunity that CMS has to make the world a better place. And so one of the first things we did was really put together 6 pillars to really guide how we would think about our work. The first of that is advancing health equity, because that is, of course, what the goal is, to give everyone an opportunity to live, to attain their highest health outcomes. Really hearing from stakeholders is our third pillar, of really wanting to make sure there is a part of that our work really reflects the people who are served by our programs and who are the ones who deliver care. And then building on coverage and care, our second pillar, making sure we are thinking about innovation, our fourth pillar, and of course, making sure that we are good, trusted stewards of the programs have been a core part of our work.
I think just to add to that, the key aspect for us going forward is to ensure that CMS programs treat patients, consumers, beneficiaries as one consistent program. For too long, we have operated as Medicare and Medicaid Marketplace being separate programs. And the observation is that people change circumstances. They move from one program to the other during their lifetimes. And what we want to do is focus first and foremost on the person and ensure that they have a seamless experience going from one program to the other, to ensure they have really consistent care, better care through their lives, can experience that is simple, common, and seamless.
What I think needs to be changed about healthcare is more education around maternal health. I experienced both preeclampsia and then HELLP syndrome actually postpartum with my pregnancy. And in the midst of a very dangerous health syndrome episode, I had to advocate and educate the hospital staff during a really critical time. And so while HELLP syndrome and preeclampsia are rare, many women do experience them. There are a multitude of pregnancy complications and challenges that the healthcare system should really be more educated about. I love the work that I do. I really enjoy being an advocate. I really enjoy educating so that no other family, no other mother has to experience what I experienced, which should have been the most joyful time of my life, turned out to be one of the most scariest. And while I enjoy the advocacy work, it really should not be on my shoulders or patients' shoulders to be educating the healthcare system. And so because the maternal mortality rates in our country are so high, something really needs to change. And I hope that we are moving in that direction.
That laid great groundwork for today's conversation, and I'm very happy to turn it over to Frederick Isasi at Families USA to talk about questions they have for you.
Administrator Brooks-LaSure and John, thank you so much for being here. It's a real joy to be able to join with you and really dig into some of the biggest priorities for the folks that we are all working on behalf of the American families and people. For so long, the healthcare movement has focused on ensuring that all people in our nation have access to high quality, affordable health insurance. That's an incredibly important goal and one we haven't achieved quite yet. At the same time, there's such a deep and growing awareness that the current system is not delivering high quality healthcare and achieving the ultimate goal of health. And this is particularly true for communities of color, rural America, and immigrant communities. A hallmark of the Biden administration's healthcare work has been a focus on ensuring we achieve equitable access to health in our nation. What are your most important accomplishments to create a fair and more equitable access to healthcare?
I think there's one kind of fundamental perspective is that we don't see equity as a side project, but it's really a core management philosophy that runs through every decision that we make and every choice that we make. So whenever we're deciding how to set payment, how to build models for better payment, that lens drives each decision that CMS makes. Things like how we assess patients for social needs better, how we think about the execution of connecting people to services. And I think in the past year, we have changed the conversation. We have set in motion many different policy initiatives. And going forward, the work will be not just how we define the problem, not just how we set the data collection, the quality measurement systems, but really how we execute and deliver services better to all Medicare, Medicaid, and private consumer beneficiaries.
I was just going to say, John captured it really well, just how important it is that in all of our decision making that we are thinking about what are the unintended consequences and making sure we adjust. And just to give some specific angles, I think maternal health is one where we say coverage is important, and we are so excited that the American Rescue Plan gave states the opportunity to expand postpartum coverage, but coverage isn't sufficient. We have to change the care. And so we're looking across all of the agency, what levers do we have, and looking at our quality levers, looking at our requirements for hospitals, looking at the Medicare program, and really trying to make sure that we are tackling these issues in a systematic way, that we are really, as John was talking at the beginning, of making sure that we, I like to say across all the M's, are really trying to make sure that we are using our levers. And by M's, I mean Medicare, Medicaid, and CHIP and marketplace coverage.
Thanks, that's real. And we are so proud of the work that we've all done to make sure that that postpartum care is available for moms and new babies, to make sure they're getting the health care they need. It's so important. And just digging in a little bit deeper on this issue, one of the things that we're very focused on at Families, a lot of the other folks in this conversation are as well, is really trying to understand the magnitude of health disparities in our nation. We can't really change what we can't understand and measure. And so just digging a little bit deeper into this question, what is CMS doing to close the equity gap through the hospital and physician quality payment programs? For example, we're really interested in efforts to collect and then disaggregate data sets to begin requiring hospitals and physicians to stratify quality based on and outcome measures based on things like ethnicity and age, language, disability status, gender, those sorts of things. What can we expect there?
Going forward, what folks should expect is all of our different quality programs, be it for hospitals, be it for ACOs, be it for health plans, will begin the requirement that those entities report, collect much deeper data that's stratified by geography, by income, really pushing the envelope for how we assess changes in care. And so what we want to see going forward is not just the average goes higher, but really that for each group that's served by programs, by hospitals, by different entities, they're asking the right questions. They are challenging their own systems to say we want to see care improvements for all patients, not just the average, and that drives through every payment system, each model of care that CMS maintains.
Thank you so much, John. Another issue, that we talk about a lot, particularly facing vulnerable populations, is efforts to be healthy and the ways in which social factors intersect with people's health. This could include things like access to safe and affordable housing or behavioral health, providing continuity to healthcare for justice-involved populations, helping new parents to be successful, addressing adverse childhood experiences, ensuring access to high quality and nutritious food. There's a big sort of group of social factors that can really drive the ability of people to live a healthy life. And we were wondering, how is CMS planning to prioritize reorienting the system towards those social determinants of health in the next couple of years?
So I would start by saying, I really think that this is a combination of efforts. As John was saying, we are really trying to make sure that we are measuring so we can see some of these issues. And so making sure we are asking the questions that need to be asked in terms of, are there other factors that are keeping people from not being able to use the healthcare system that really are related? I think we're seeing states who want to, using their waiver, coming to us with their waiver authority to think about how to use the Medicaid program dollars in a different way, certainly across our other programs. I would also say it's about us at CMS really making sure we are working very closely with other parts of the government, and other types of organizations so whether it's at HHS, so many of our partner sister agencies, as you saw earlier, that last week we sent out a letter with 6 agencies. And why? Because we want to be good partners and really try to make sure that we are leveraging all of the federal dollars in ways that are really going to make a difference and that we're coordinating care. And so that's a big part of how we're thinking about things, to make sure that we are really looking at what people need, as John was saying, like being more focused on the person. And I would just add that in our thought around health equity, it's not just the people who are underserved, it's also the providers and the other entities that serve the underserved. And I see that also as being part of our work in really making sure that we're bringing community workers who are, I like to say, health adjacent, but they are important to the healthcare system and really need to be integrated in a better way.
Thank you so much. A terrific point. And we're with you on the notion that we've got to make sure that the providers and the communities are well resourced in these to help folks to address those social needs. So thanks so much. It's a pleasure talking to you guys.
Hi, my name is Elisabeth Benjamin, and I work at the Community Service Society of New York. My organization works to promote economic justice, racial equality, and essentially power New York to have better policy solutions that work for working people. I run the health division at CSS, and what we have seen year after year, day after day, as we help over 150,000 consumers either enroll in coverage or use their health insurance coverage or otherwise try to navigate our very difficult, if not Byzantine, healthcare system, is that people need help. Our system isn't working. Our healthcare system's incredibly expensive. It is patchwork laden. And it is really hard for regular people to use. We must and can do better.
Hello, Administrator and John. I'm Emily Stewart. I'm the Executive Director of Community Catalyst, and really grateful to be in this conversation with you. I wanted to start us off by talking about the issue of medical debt. Many healthcare advocates across the country are hard at work tackling the issue of medical debt at the state level. And I wanted to know, is CMS open to learning more about those efforts underway by those advocates and how they might inform federal action? And if so, what would CMS's approach be to learning and engaging with advocates at the state level on this critical issue?
We have been focused over the past 6 months on, just really 12 months, to implement No Surprises Act, and that work has gone well. We have processes now in place. As all new legislative work goes forward, they evolve, and we have to learn regarding how we operate better, how we build policies, regulations for the future. One of the principles that we have put forward throughout the agency is that we are going to capture the experiences from the ground before CMS makes policy going forward. So we are deeply committed to both making sure all stakeholders know about CMS programs, but also that those same stakeholders have the opportunity to inform. We have challenged the 10 CMS regional offices to really scan the field and both educate, but also capture back feedback. And so we have changed how we operate. We have changed how we collect information to really capture that on the ground experience. So we are going to be traveling both physically, but also virtually to all parts of the country. We welcome the feedback, we welcome the criticism, we welcome the conversation for how we implement better, particularly around policy areas that are new to CMS. Regulating private insurance, regulating how consumers get their care from non-CMS programs, that's new work for CMS. And so we are deeply motivated and deeply interested to capture the feedback, to make policy for the future, and to do it better.
I really appreciate that point about learning and adjusting as the agency moves forward. And I think one of the things that we have learned along the way is that passing a law or a policy that gives people a certain set of rights doesn't necessarily mean that they are aware of those rights. And indeed, one of the biggest challenges is that people are often not aware of the rights that they have under the law. And this is an issue for many aspects of health equity and health justice that impact both people's health as well as their financial well-being. So that includes things like their right to access financial assistance from nonprofit hospitals, or as you are stating with respect to the No Surprises Act, potentially their awareness about their rights under that law. I'd love to learn more about how the administration is thinking about public education in this moment, how the agency is thinking about its role relative to community leaders and advocates across the country. And I have a second part to this question, which is around language access. Importantly, for many people, English is not their first language. So I would love to understand how the administration is thinking about public education in various languages.
This is an issue we spend a lot of time on at CMS, across HHS as well. But I think it's so, and we've seen what a difference it makes when we engage in terms of outreach. I mean, the ACA numbers, the enrollment numbers are proof that when you actually make sure that people know what they're eligible for, a lot of people are excited about it. And that is something that we are focused on across all of our M's, to really make sure as we eventually get to the Medicaid unwinding, the public health unwinding, of making sure we hold on to coverage. We are thinking about that in the Medicare program, of the savings programs that help. And then, as John was saying, on No Surprises Act, I think about it a little bit like I started out my career working on the CHIP program, and when it was a little baby, right, like just really going state by state to get people enrolled, and it changed children's lives. Like I went around the country then, you know, of really hearing about what a difference it made. And same with the ACA. And I think now we're in that next stage of educating people more broadly about vaccines and boosters and getting preventive care and all of that. So that is very much a part of what we are thinking about during our open enrollment periods, where often we have the attention of people in a different way, as well as engaging on some of these other issues. And then when it comes to language access, this is a huge priority of the administration, to make sure we are looking again across the 3 M's about making sure that we are using our authority and really encouraging or requiring additional access for people as we start to learn more and as we start to increase our reach.
Thank you so much. I'm so glad that you mentioned the record-breaking enrollment under ACA marketplaces this year. And of course, a major driver of that was that health plans became more affordable this year. And so I wanted to ask about this issue of affordability. It's one of the biggest issues, as you well know, in healthcare and people's lives overall. And it's not just an issue of health, it's also an issue of just overall financial well-being. It's about car payments and rent and putting food on the table. How has this administration prioritized making healthcare affordable, and how will this important work continue?
I think one of the best examples, but not only example, is the commitment for how we're thinking about prescription drug pricing. This is not simply about trying to save money for the Medicare trust funds, but to think about policies that can drive savings to people. We see in our data, just taking high prices for drugs, that it causes care disruptions. It causes life disruptions. We get letters from beneficiaries that are just having challenges staying alive. And so I think that is one example, but not the only example. But we think of policy work going forward as the first priority is to improve access to healthcare. There could be secondary benefits like savings to the trust funds, but first and foremost, drive commitment is better connection to healthcare services, which starts with those services being affordable, having much stronger access. But I think the commitment to lowering prices for and prescription drugs for all of our programs demonstrates that deep commitment.
Thank you so much.
What we know is that 20% of our health is taking care of systems outside of the healthcare system, social drivers of health. First, do no harm is the oath I took as a physician before I ever started taking care of patients. And so what we must do is hold our healthcare systems accountable to practicing harm reduction. What we know is that trauma is ubiquitous, with those childhood experiences putting a physiological and psychological imprint on us that affects our health as adults. So we have to hold ourselves accountable to trauma-informed systems, understanding the trauma of racism, oppression, marginalization has to be included in that calculation. What we know is that for chronic relapsing remitting conditions, behavioral health, substance use disorders, physical health included, fee-for-service reimbursement infrastructure drives health inequity, decreasing access, decreasing emphasis on quality. And so what we must do is build systems that are value-based and population-based in reimbursement so that we can take care of the other 80% of health in harm reduction and trauma-informed systems.
Thank you again for your time today. You came into the office more than a year ago during a global pandemic, and as we gather today, we're reflecting on more than 1 million lives lost and another surge underway. And the pandemic has changed so much about our lives and how we work and how we engage and see one another and socialize and how we go to school. And importantly, how we get our healthcare and perceive our healthcare system and how it's working. We hear from people across the country that they want a healthcare system that will treat them as their whole person, not as one body part, or that they will have doctors that stick with them over time. And each visit they have gets the attention they deserve. Really, in essence, what they're talking about is a healthcare experience that is focused on healthier lives and delivering value, though they never use the word value-based care. I'm curious, as you guys are thinking about your role in really driving our healthcare systems, care innovation and payment innovation, how you describe the promise of value-based care and your plans to bring more innovation and care and payment into the healthcare system.
So our team has set a very wide sweeping goal that all Medicare and Medicaid beneficiaries will have the opportunity to be served by accountable care. And it used to be the notion that we wanted to promote care reform, delivery system reform to save money. But now with the pandemic, the need is different and the need is urgent. Those that suffered the most were those that had higher incidences of chronic disease. Those that suffered the most were those that couldn't transition to home post-operation, for example. So we see the need for more care transformation, more delivery reform to support patients better, to keep them healthier, to slow, delay, reverse chronic kidney disease, to help people transition back to home. They're not living in a nursing home that has really more danger. So if we do value care well and truly transform delivery, we'll not only save lives, we will keep people healthier, more resilient to whatever the current pandemic brings to us.
And John, you guys have talked a lot about, as the administration, you're very interested in working with the private sector or providers to really build out this work in value-based care. How are you engaging stakeholders in this lane of work?
Our team has gone out to the field and has held countless listening sessions that have taught us that we need to focus more on how patients receive their care, to build models that really capture the core care need that they have. I think in the prior worlds, the work was focused on how we set payment, build risk adjustment, set very complicated payment rules. They're still very important. But what we've heard is we have to build models that reach all people. We have to build models that really meet people where they are within the care system. But those listening sessions, one, they teach us, but two, they have really changed the strategy going forward to drive deeper spread and better engagement from patients directly.
Great. And then switching gears a little bit, although payment reform and care innovation is so important here, would love to talk about both the issues of maternal health and mental health. And as we've gone across the country and talked to people about their healthcare experiences and the solutions to make the system better, one area that people prioritize is the need to provide better maternal and newborn care, as well as the huge strain that people are feeling in their mental health, whether that's in access or provider shortages. And really, this is falling the hardest on underserved and overlooked populations. How are you thinking about both this issue of maternal health and behavioral health, and what steps is the administration doing to make this better for people?
It really does connect to our previous comments around value-based care, that this is exactly right. When we talk about that as a concept where we really need to drill down and talk about some of the specific areas, and maternal health is such a place where we need better coordinated care. And one of the things that we have been doing, and as folks know, this is a priority from the vice president down to me in terms of just the whole of government being really focused on making sure we tackle maternal health. We are really trying to engage with stakeholders as we have this discussion. I recently did a site visit with Dan Tsai, where we were in Cleveland, Ohio, and it was very moving to see how a variety of stakeholders, the hospital, the city council, just to see all of these other entities that were really trying to tackle this, both from the mother side and from the infant side. And so some of the things we're doing is really trying to use, as I was saying earlier, just all of our levers. So the birthing friendly designation of really looking at the hospitals, of really making sure that we are measuring quality, and we've started there this year with asking if they're in a collaborative, but we'll continue to build on that over time, and really welcome comments from stakeholders about the types of things we should look to. Expanding coverage to women postpartum for 12 months after the postpartum event, after the birthing event. So key. I think of my own experience 2 months after, of trying to get to the doctor while trying to figure out what to do, and the idea of having to change coverage in the middle of that is a huge problem in our country, right? Of in the middle of when you're just trying to make sure you can survive, to have to worry about your insurance changing is a real problem. But really making sure it's strong care, that it, and measuring. And right now we are CMS looking at our data, looking at the Medicaid data, trying to draw lessons from that, and really wanting to bring the private sector into that conversation. We know many are making commitments, and we really want to make sure that we are all learning what is best so that we can address such a critical issue. And same on mental health. That is a huge priority of the Secretary and HHS, and we CMS participate in the Behavioral Health Committee. It's, as we know, it's a real crisis, particularly for I think people at both ends, right? The children in our country across the board, but certainly in the most underserved areas. Just what is happening as a result of the pandemic is something that we have got to address. And then on the other end of the spectrum, people, as John was mentioning, who were not able to be in the setting that they wanted to because of so many issues. So we are really tackling this, working with the other agencies, but really thinking about it when we think about what's going on in our kid coverage, of trying to make sure people have access to mental health services, because of course those are covered in Medicaid, and then in our nursing home strategy of making sure we are including that in as we think about people on the other end of the spectrum.
Great, thank you. And one question that this leads naturally into is virtual care and how you're thinking about it. And the pandemic really showed us that was a tool that we could utilize in our healthcare system. And it is a tool that we believe can address inequities if used in the right way. Do you have any comments on how you're thinking about virtual care and using this as a tool to really reach people that have traditionally lacked access to healthcare?
We've certainly in the Medicare program, as you're seeing, we're making extending that coverage. It's available in states have those options as well in the Medicaid program. John, anything you wanted to add there?
I think it's fair to say that telemedicine, telehealth saved the healthcare system during the pandemic, but CMS rules today pay for a service when the physician chooses to offer the service. And what we want to get to is a world where all Medicare and Medicaid marketplace beneficiaries have equal access and the same chance to receive that service. So while telemedicine was a tremendous force during the pandemic, it's still a permissive policy, meaning that physicians have the right to bill for it. Where we want to go is all consumers, patients, families have the right and have equal access to those services.
At Hispanic Unity of Florida, we provide healthcare benefits enrollment assisted, and we see the positive impact this program has. But there are nearly 1 million Floridans who, because of income limitations, don't qualify for any healthcare coverage. HUB's goal is to help immigrant families, but recently we have been assisting more non-immigrant families. This shows this is an issue affecting all Floridians. We hope to find solutions that will close the coverage gap so all Floridians can have access to affordable health care that will lead to healthy lives.
Great. Thank you for your time today. And I'm very excited to hand it over to Rita for the next set of questions.
Thanks, Natalie. So Administrator and John, it's great to be here today with you both. One of the areas that UnidosUS and our affiliates and many of our partners here today, we've been working together in ACA enrollment and timely access to coverage. And, you know, I think the most recent open enrollment period, we had 14.5 million Americans signed up for the marketplace for health coverage, including more than 1.8 million Latinos. So what do you think were the key factors that led to this record-breaking success in reaching and enrolling more people this year?
I would start by saying it's both and. It's certainly was the outreach effort. And we know that because at the start of the Biden-Harris administration, even before John and I arrived, we saw a huge bump up in ACA enrollment because of the outreach efforts. We were able to do that starting with the special enrollment period because of COVID, but then just tremendous levels at open enrollment this year, particularly with navigators, people who are on the ground helping to enroll individuals one by one across the nation. And then the and part is the American Rescue Plan and the difference that the subsidies made. There are so many statistics that we have been putting out and will continue to put out, but I can't forget hearing the story of a particular person in Delaware who, when she found out, she got called by a navigator and heard that her premiums were going down $70 a month, and then just a couple weeks later was prescribed medications that cost around the same amount, was then able to pay for those. So just the difference that this coverage, these increased subsidies has made a difference for millions of people.
One of the things that CMS life is that we are tremendously reliant on partners and teams that don't work for CMS directly. And I think the huge jumps that we saw this year, during 2021, is really testament to how the system works, that we set regulations, set payment policy, but rely on those trusted partners to really communicate and to implement CMS policies. So we could not be more grateful to all the support throughout the country, and just reinforces how the system works of a very delegated, very on the ground, consumer-oriented network that we trust and have tremendous pride in.
Great, thanks, John. And Administrator, I know the difference of affordability makes the world in terms of, having to choose between having food on the table or being able to afford your medication. And I know that many of our affiliates, including our promotoras de salud or our community health workers, were part of that effort as well. The pandemic has really focused on equity and made us look at equity in a different way, right? And it was really involved in a whole of government approach, right? To connecting Americans, to connecting diverse communities, to timely healthcare services such as the COVID vaccines, tests that we needed, and other social services that we need to continue to have, right? So I think in looking back, especially at the height of the pandemic, and what lessons, have you learned from conducting outreach during the pandemic, and in terms of helping people enroll and connect them to more Americans to coverage through Medicaid, through CHIP, and the marketplace, which was really instrumental.
I think for me, one of the great lessons is that the safety net works, meaning that the CMS programs flexed tremendously to cover more people. And I think one of the learnings that we've taken here at CMS is how we maintain that continuous flexibility to grow, to expand, to enroll more people during a tremendous time of need. And what I think the greatest lessons in healthcare will be is that the ACA foundation that was really built upon by the Congress really flexed to serve tremendous need. And going forward, we have to maintain that. We're probably going to be in a world of continuous challenge, and the real learning and the real kind of gratifying work is seeing that tremendous flexibility to our programs that can respond to tremendous need.
And likewise, just building on that thought, I think we, CMS, we, the government, ended up connecting with entities that we don't always talk to because we needed to partner to solve the pandemic, right? And so really building the people who are the trusted partners. So whether it's the churches or the local so-and-so or the doulas or the people that help you get all of your other set of services, all of these partners need to be integrated in for us to continue to solve the pressing issues of our day. So I think that is one of the things that we are still continuing to try to figure out how to do. How does CMS continue to strengthen the relationships that we've developed over the last couple of years to solve one problem, to make sure that we continue to have those perspectives and that work integrated into our programs moving forward.
Thank you, Administrator. And John, I think it is super important to have that public and private collaboration, multi-stakeholders involved in really strengthening our healthcare system. So one of the things the last thing that I wanted to ask of you is really the Medicaid disenrollment freeze that Congress had put in place during the pandemic kept millions of Americans insured over the past 2 years. But when the public health emergency ends, states will have to begin redetermining individuals' eligibility on a massive scale, which is, to no avail. It is a lot of work, right? And so how is CMS preparing for this unprecedented undertaking? And what can partners like Unidos, like many of the partners here today, such as our community-based organizations even, and our health centers, as key trusted messengers on the ground, do to help?
So we are tremendously focused on making sure that our systems, CMS systems, and more important, that state systems are prepared for this transition. And the number one principle that we have is that any potential Medicaid beneficiary that might lose coverage, that could be eligible for any other program, that they get connected over to Medicare Marketplace. And so what is happening is that we are building connections from one program to other programs like never before to ensure that seamless transition. So we are planning, operating, connecting, validating with states that they are prepared for this transition, with the number one principle being we want to preserve coverage. The best thing that we can ask from partners, stakeholders, is to really help prepare and to educate those who are covered by Medicaid that they need to prepare, they need to get ready to give information, they need to respond when their state contacts them. But our number one priority is to preserve those coverage gains, to make sure people are connected to any other source they could be eligible for, and that states have the systems in place to carefully calibrate their processes to ensure they're smooth. And again, going back to that first principle, that they connect people to any other source of care they could be eligible for, to preserve the tremendous gains that we have seen during the last 2 years.
Administrator, you want to add anything?
Just to say that this is a huge priority of the agency and the department to hold on to whatever you're eligible for, getting you enrolled in those, and that we are, our teams are engaging with the states to really help get them prepared. And as John said, I think all of you really helping to let people know the information they'll need to provide, as well as encouraging and pushing states in terms of, we've given a lot of flexibility and a lot of suggestions about how to ease the transition. But as we know, this is a state-by-state discussion when it comes to the Medicaid program.
Thank you. Thank you for your time. I think that even having a cultural lens and an equitable lens to it all, I think it would be super important for our communities to ensure that they're aware of how to do that.
All right, well, thank you, Administrator and John. We're very grateful for your time and for your work. We're all here because we care deeply about advancing health equity in our country, and we so appreciate what you have shared today about equity being a core philosophy that is guiding this administration's and this agency's decisions, as well as your focus on making a real difference by starting with people and what they want and need out of the system. Thank you for being in conversation with us today, and most importantly, for always engaging the people who are most harmed by the system today and helping to design the system of the future. Thank you.